Okay, so this is my presentation on acute maxillary sinusitis. My name is Courtney Gould. This is for NP 612 at St. Joseph's College. So as an overview, this is an inflammation of the maxillary sinuses. So we're specifically talking about the maxillary sinuses as opposed to the frontal sinuses. It's often referred to as sinusitis or rhinosinusitis. This is due to an inflammation of nasal tissue along with sinus tissue, which is almost always the case. So I feel like probably when you're reading about rhinosinusitis and sinusitis, it's probably referring at least some of the time to acute maxillary sinusitis. But sinuses are typically air-filled cavities separated by narrow passages. They make a thin mucus that drains out of the channels of the nose. When they become blocked by fluid and swell from irritation, the sinuses become infected. So the definition and pathogenesis. Inflammation of the sinuses blocks normal drainage pathways of mucus. So this inflammation and mucus production could be the result of a bacteria, a virus, or a fungus. And it leads to mucus retention, hypoxia, decreased mucociliary clearance, and predisposition to bacterial growth. When we talk about acute maxillary sinusitis, acute is referring to a duration of less than 4 weeks. Subacute would indicate 4 to 8 weeks duration, chronic is greater than 8 weeks duration, and recurrent indicates 3 or more episodes per year, with each episode lasting greater than 2 weeks. Just as a side note, the most common cause is an upper respiratory infection of viral origin, which typically resolves in less than 14 days. If symptoms worsen after 3 to 5 days or persist longer than 10 days, bacterial involvement is suspected. And the nasal mucosa responds to the virus by increasing mucus production, recruiting inflammatory mediators, which are white blood cells, to the lining of the nose, resulting in congestion and swelling. This results in sinus cavity hypoxia and mucus retention, which causes cilia, which move mucus and debris from the nose, to function less efficiently, creating an environment for bacterial growth. So you basically have this buildup of inflammation and mucus that has a difficult time draining, which creates an environment for bacterial growth, which would be the bacterial cause for the acute maxillary sinusitis. And I think that's typically what we're talking about when we say it. So for risk factors and etiology, risk factors are having allergic and non-allergic rhinitis, hormonal conditions, the congestion of pregnancy, rhinitis of hypothyroidism, gastroesophageal reflux disease, immune deficiencies that you can see, anatomic factors, septal deviation, adenoid hypertrophy, acquired immune deficiencies such as HIV, chemotherapy, transplants, cystic fibrosis, nasal polyps, those who spend time in places where infections are common, like daycares, so it just results in probably an increase in incidence of infections in general. Allergies and asthma, cigarette smoking, swimming in contaminated water, and tooth abscess. So the most common bacterial organisms associated with bacterial sinusitis are Strep pneumoniae, Haemophilus influenza, and Moraxella catarrhalis, and I'm probably murdering those names, so I apologize. But in terms of the most common viral causes, it would be rhinovirus, coronavirus, influenza A and B, parainfluenza virus, and the respiratory syncytial virus. So subjective data. Pain or pressure over the cheek, possibly radiating to the frontal region or the teeth. It often increases with straining or bending down. So the maxillary sinuses are located in the cheeks, like you can see here. So there might be pain there or pressure. Tenderness to pressure over the sinuses. You might have complaints of postnasal discharge, and you might actually see it on a physical exam as well, which isn't on this slide, but a blocked, stuffy nose, persistent coughing with pharyngeal irritation, facial pain, hyposmia, and anosmia, nasal drainage or congestion, cough, fatigue, maxillary dental pain, ear pressure and fullness, and halitosis. So physical findings, you may see redness of the nose, cheeks, and eyelids, purulent nasal drainage, purulent drainage in the posterior pharynx, focal facial pain with bending forward, unilateral sinus tenderness, and halitosis. You may also have a fever. So differential diagnoses include a viral URI, allergic rhinitis, not allergic rhinitis, dental abscess, headache, nasal foreign body, or Wegener's granulomatosis. Diagnostic tests. So the gold standard for diagnosis is a direct sinus aspiration culture, but it's not routinely practiced due to the invasiveness of the procedure, and it's impractical and only used when you need a precise microbe for identification in order to treat it. A CBC may show elevated white blood cell count. A CT scan may be helpful, but mostly when you're evaluating a recurrent sinusitis. Transillumination, opacification with air fluid levels. Allergy testing may be helpful. I guess if you think the cause is, or one of the contributing factors is allergic rhinitis that's contributing to like an acute maxillary sinusitis, especially if it happens multiple times, allergy testing may be helpful to determine, I guess, the cause of the allergies and what you can do to prevent them. And then sinus x-rays may be useful as well. So this slide is just a few clinical guidelines for the diagnosis of bacterial rhinosinusitis. And children and adults, I'm sorry it's so small. I had a hard time figuring out how to make it bigger without making it blurry. But I can send anyone a copy if they're interested. So the plan of care for someone with acute maxillary sinusitis would include avoiding environmental irritants, smoking cessation, increasing fluid intake to thin secretions, elevating the head of the bed, patient education. That can mean like all of the above, but also including like any medications that they're on, etc. Pharmacologic management if it's determined that it may be bacterial in origin, or antibiotics for patients with acute and moderate to severe infections with amoxicillin clavinate or doxycycline levofloxacin or moxifloxacin if there's a penicillin allergy. You would want to manage the allergic rhinitis, which may include a referral to an allergist, medications, and determining and avoiding allergens. If there's no improvement in 3 to 5 days of a sinusitis, then you may want to consider changing to an antibiotic that broadens coverage or covers resistant bacteria. If there was partial response but not complete, consider an additional 10 to 14 days with the same antibiotic. They can use Tylenol or ibuprofen for a headache or other pain that they're having, decongestants, saline irrigation, and if there's still no improvement after another antibiotic, you may want to see a specialist or send your patient to see a specialist and consider imagery, especially if this is recurrent.